This is now the same patients with, remember, episodes of atrial fibrillation diagnosed with the PR logic or with the wavelets, and we could find in the memory of the device an episode classified VT requiring 5 sequences of ATP. You can see here the burst and a ramp. And if you look carefully at the tracing, you can see that initially this is really in favor of conducted atrial fibrillation, but now just before the delivery of the first burst, you can see some slower atrial signals, and these may correspond to atrial undersensing of the atrial fibrillation. Now, if you look carefully at the EGM, you can see that initially there is an appropriate diagnosis of atrial fibrillation, but just before the delivery of the first therapy, you can see now there is clearly undersensing of the atrial signals. And remember that an important step of the PR logic algorithm is the comparison between the atrial rate and the ventricular rate. Here, for the device, the ventricular rate is faster than the atrial rate. So there is a diagnosis of ventricular tachycardia, and then the inappropriate therapies will be delivered. If you program both the PR logic and the wavelets, the only case where there's going to be an analysis of the morphology of the signals is that when there is a diagnosis of dual tachycardia with the PR logic, so both atrial fibrillation and ventricular tachycardia. So, like in this example, if there is a sustained atrial undersensing, you need to remember that the device will arrive to diagnosis of ventricular tachycardia without analyzing the morphology of the signals. So if in a patient there is a sustained atrial undersensing, you clearly need to deprogram the PR logic, which is based on the comparison between the atrial signals and the ventricular signals. And probably that in patient with atrial undersensing, you need to program only the wavelets, and the discrimination will be based on the analysis of the morphology of the ventricular signals.